Good evening, everyone. Welcome, welcome to monthly journal club. Since
अमर आवाज येत नाहीये.
हॅलो, आवाज येत नाही अमर.
Second Saturday.
Is going on. That's why
We have shifted it on Friday. Today there are two presentations. One by Dr. Amruta. She is a NNF fellow in Apple Hospital, Kolhapur. Senior resident in CPR Hospital, Kolhapur. I welcome you all and I request Dr. Amruta to proceed.
Good evening, everyone, and thank you for giving me opportunity of presenting this journal club in KAP. And I will share. Can I share my screen?
Yes, yes.
So today I am presenting a journal club which will throw light on the role of erythropoietin in perinatal hypoxic ischemic encephalopathy. So this is the article which is published in Journal of Perinatal Medicine in January 2019. Introduction. It is erythropoietin appears to reduce the risk of brain injury in perinatal hypoxic ischemic encephalopathy. Many randomized clinical trials are done before, but evidence is unclear. So this meta-analysis was done to study the role of erythropoietin in HIE and its outcome on mortality, neurodevelopmental impairment, and cerebral palsy. It is a systematic review and meta-analysis of randomized and quasi-randomized control trials. Types of participants. It is means term and late preterms more than 34 weeks with moderate and severe HI according to the Sternat staging are taken, and one of the following criteria of perinatal depression was taken, that is Apgar score 5 or less at 5 minutes of birth, acidosis within 60 minutes of birth, and need for mechanical ventilation or resuscitation at 10 minutes of birth. Methods. Intervention, erythropoietin or its analog darbepoetin alpha is used in study groups, and in control groups, no intervention or placebo was used. Erythropoietin or its analog was used with or without hypothermia, intravenous or subcutaneous, and it was used within 24 hours of life. So this is a flow diagram showing the stages of search results and filtering process. Records were taken through the database. 420 records were taken, and they were screened, and full text articles assessed for eligibility were 18. In that also, only 6 studies were taken for quantitative synthesis and qualitative and quantitative synthesis. Other 12 studies excluded because of certain reasons, like no outcome assessed or duplicate trials, no retrievability. Case control study. So outcome measured as a primary outcome, secondary outcome, moderate to severe neurodevelopmental impairment at 18 to 24 months. And this moderate to severe neurodevelopmental impairment is defined as presence of one or more of the following. That is cerebral palsy, moderate to severe cognitive impairment by Bayley score, severe visual impairment, and severe hearing impairment. Secondary outcomes defined as death before discharge or at 18 to 24 months, moderate to severe neurodevelopmental impairment, cerebral palsy, moderate to severe cognitive impairment or brain injury on T1, T2 weighted images of MRI during the first 2 weeks of life. Injury to one of the following regions of the brain like cortex, basal ganglia, thalamus, posterior limb of internal capsule, then brainstem or cerebellum. So 6 studies were analyzed, that is total 454 infants were taken and 3 studies were blinded randomized control trials and 3 were non-blinded. Drug used in one study was darbepoetin alpha and other 5 studies erythropoietin was used. In 2 studies, therapeutic hypothermia was also present, and in other 4 studies, only erythropoietin was used. No therapeutic hypothermia was given. So, meta-analysis was performed on following outcomes. On primary outcome, meta-analysis could not be performed because of the methodological heterogeneity. And on certain secondary outcomes also, it was not performed because that outcome was present only in one trial or not present on any trial. So meta-analysis was performed on mostly on secondary outcomes, that is secondary outcome of death, in which EPO was used without hypothermia or EPO was used with or without hypothermia. Secondary outcome of cerebral palsy, in which EPO was used without hypothermia, and moderate to severe cognitive impairment, in which EPO without hypothermia was used. And also in secondary outcome as brain injury, in which EPO was used with or without hypothermia. Other outcomes could not be studied because of methodological heterogeneity or outcome reported only in one trial or by no trial. So, according to the outcome, when erythropoietin was used without hypothermia, there were 3 outcomes were studied, that is death, cerebral palsy, and moderate to severe cognitive impairment. For death outcome, risk ratio was 0.89. That is, certainty of evidence was low. And for cerebral palsy and moderate to severe impairment, the risk ratio was 0.47 and 0.49. So certainty of evidence was moderate. That means there was a decrease in the risk of cerebral palsy and moderate to severe cognitive impairment, which was statistically significant. But there was decreased risk of death also, but it was not statistically significant. Then when erythropoietin was used with or without hypothermia, 2 outcomes were studied, death and brain injury on MRI. In that also, a decrease in the risk of death was also seen, but it was not statistically significant, but statistically significant decrease in the risk of brain injury was seen. This is same, but it is means expressed in the forest plot diagram plot for the comparison. Is we can see when the outcome death was studied with or without hypothermia, then that time that diamond is touching the line of unity. That means there is decrease in the risk, but it was not statistically significant. Same outcome was present when death was studied when erythropoietin was used without hypothermia, and when outcome of cerebral palsy or moderate to severe cognitive impairment was studied. That time diamond was present on the left side of the line of unity, which is not touching the line of unity. That means there is decrease in the risk of cerebral palsy and moderate to severe cognitive impairment, which is statistically significant. So let's see some things about the erythropoietin. It is a glycoprotein which is secreted by kidneys and brain in response to hypoxia. It is a primary hematopoietic growth factor which is responsible for the erythropoiesis. And in brain, it acts as a neuroprotective agent. Its neuroprotective effect is exerted by its anti-apoptotic property, anti-inflammatory effect, and antioxidant effect. It can be given as an intravenous route or subcutaneous route. Both routes are used in neonatal practice, but limited data to conclude one over another. Hello.
Yes, madam. Continue.
Two dose regimens are discussed. That is low dose regimen and high dose regimen. The low dose regimen is initial dose of 300 to 500 units per kg per dose, which is followed by maintenance dose, which is given IV 300 to 500 units per kg per dose every other day for 2 weeks. And in high dose regimen, IV erythropoietin is given 1000 units per kg per dose once a daily on the day of life 1, 2, 3, 5, and 7. Substantial clinical implications with high dosing compared to low dosing. Further research is required, but further ongoing trials are using high dose regimen. So outcome of the erythropoietin use as a monotherapy or adjunct to the therapeutic hypothermia will be similar or not is very difficult to study from this review, but one can certainly say that there is lower adverse events with EPO with hypothermia due to the additive neuroprotective effects. So same as I mentioned before from the forest plot diagram, it is there is reduced risk of cerebral palsy and moderate to severe cognitive impairment in infants treated with erythropoietin without hypothermia, and reduced risk of injury to the brain on MRI was seen in infants treated with EPO with or without hypothermia, and trend towards the lower risk of death in infants treated with erythropoietin as monotherapy or adjunct to the hypothermia. So we can conclude from this study that erythropoietin administration in neonates with perinatal HIE reduces the risk of brain injury, cerebral palsy, and cognitive impairment. The evidence is limited to suggest its role as an adjunct to the hypothermia. Larger trials are underway to overcome this limitation. These are some undergoing trials which are for this outcome. These two trials are MAIN trial and HILL trial. Results are awaited in 2022. So take home message is that in certain settings of NICU with low resources where therapeutic hypothermia cannot be used, we can consider erythropoietin to reduce the morbidity in babies with moderate to severe perinatal hypoxic ischemic encephalopathy. Thank you.
Thank you, Amruta madam. Any questions from audience?
Amruta, did they mention at what time did they, Amruta?
Hello, hi, yes ma'am.
Did they mention at what time they given subcutaneous injection of EPO? I mean, within 2 hours?
Within 24 hours.
And they didn't mention about the grading of HIV that time, whether baby was in HIV grade 2.
Moderate, according to the Sarnat staging, moderate and severe.
Moderate and severe within 24 hours.
Yes.
Because that will depend, the outcome will depend on this thing. No? So,
Hello.
okay.
Is it mentioned that a way to give better results?
In all studies, it is given within 24 hours. Actually, that we can't say whether to early or late, but in all, it is given in within 24 hours.
What about this?
Because timing, because therapeutic hypothermia is depend on timing.
Yes, it should be given within 6 hours, therapeutic hypothermia, until 72 hours. But in this also, it is given within 24 hours. It is recommended to start this EPO regimen within 48 hours first.
What about its availability and cost?
Erythropoietin, actually, it is available easily. Cost, okay, I will have to check the cost.
The cost is not much. It is like 500 to 1,000 rupees for there. It is available in different, like 2,000 international unit, 5,000 international unit, and 10,000 international unit. And cost is like 1,000 or 500 to 1,000 and 2,000.
Okay.
It is not very costly.
Vijay, did you use in your setting?
Yes, yes, ma'am. Yes, ma'am. We use.
In Apple, do you use? Okay.
Yes.
How long to use as per these guidelines?
Many trials in high dose regimen, that is on a day of life 1, 2, 3, 5, and 7. 1,000 unit per kg per dose.
Okay.
Okay. Good.
Thank you, ma'am.
Thank you, Amruta madam. I request our next speaker to continue.
Yes. Hello. Hello.
Yeah, Subhash sir, you are audible.
Yes. Good evening, everybody. I'm just sharing my slide. Hello, sir.
Yes.
Yeah, continue.
Hello, sir.
Continue.
Yes, Subhash.
Okay, sir. Okay. HIE pediatric advanced life support updated 2020. More breaths, less fluid, and focus on the recovery. American Heart Association 2020 guideline with their changes for pediatric basics and advanced life support were discussed in 3 headlines: pre-arrest, intra-arrest, and post-arrest care. Pre-arrest care, ECLS and EC children with myocarditis. Newer evidence that has emerged since the last guideline shows that pre-arrest use of extra support or mechanical circulatory myocarditis may lead to better organ support and prevention of cardiac arrest. Children with acute fulminant myocarditis had a 75% survival with after ACLS or MCS, either with recovery of native function or post-cardiac transplant. Research in septic shock type of fluid, the newer guidelines suggest that balanced and unbalanced crystalloid as the initial fluid of choice in the septic shock. Initially, balanced crystalloid with composition closer to that of normal human plasma were postulated to reduce the incidence of hyperchloremic metabolic acidosis and AKI. Then volume of fluid in recent guidelines suggested fluid smaller liquids into 20 ml per kg. Careful reassessment for both fluid responsiveness and overload after each bolus to titrate further therapy. The last AHA update in 2015 has recommended cautious fluid resuscitation in setup with limited access to intensive care resources. But in current 2020 updates, recommended it uniformly, either resource limited or resources available setting, use fluid cautiously. Inotrope during septic shock. This is the first time the AHA has made such a recommendation for use of inotrope specifically for septic shock, based on two important trials demonstrating superiority of adrenal over dopamine in pediatric septic shock. The American College of Critical Care Medicine recommended use of either adrenaline or noradrenaline in septic shock depending on its cold or warm nature. The distinct into been abandoned by newer guideline. Noradrenaline, however, has been found to be safe, effective as the first line agent in the pediatric septic shock. This is the comparison of recent guidance with previous 2010 and 2015. ECLS or eCPR, that is ECMO in children with myocarditis. Previously, it recommended for only acute fulminant myocarditis, but recent guidelines suggest acute myocarditis with arrhythmia, heart block, ST segment changes, or low cardiac output, we can use this ECMO. Resuscitation septic shock, that previous guideline also suggests that cautious use of fluid for resources limited setting. But in recent guideline, use the fluid cautiously and reassess after every fluid bolus for fluid responsiveness and sign of volume overload. Then previously fluid bolus is either 20 ml per kg to infant or children with shock is reasonable, including those with conditions such as severe sepsis, malaria, or dengue. In patient with septic shock, it is reasonable to administer fluid 10 ml per kg or 20 ml allocates with frequent reassessment. Recent guideline more focus on reassessment for volume overload or vital parameters to assess the recovery of patient also. In intra-arrest care, advanced airway during CPR, it has been seen in one prospective and two retrospective studies that endotracheal intubation and bag and mask ventilation has a comparable outcome in out-of-hospital cardiac arrest in children. Comparative data is, however, not available for in-hospital cardiac arrest. A respiratory rate with advanced airway. Newer evidence has emerged with higher respiratory rate may improve survival in children undergoing CPR with a rider that overventilate may lead to hypotension. Thus, the rescue breath should now be given at the rate of 1 breath every 2 to 3 seconds. That means 20 to 30 breaths per minute when advanced airway is in place and while performing chest compression. Cuffed endotracheal tube. It may be reasonable to use cuffed or uncuffed ETT in the infant and children. Cuffed tube improve the ventilation, reduce the incidence of endotracheal tube changes leading to less trauma. Choose an appropriate size and maintaining cuff pressure less than 20 to 25 centimeter of H2O. Cricoid pressure, contrary to previous guideline, which recommended routine use of cricoid pressure in unresponsive children, the current guideline recommended it in select case primarily to prevent stomach insufflation. Newer data has shown that cricoid pressure during intubation and ventilation did not result in lower rate of regurgitation while decreasing success rate for first attempt intubation. Early epinephrine, both guidelines advise early epinephrine, but it is specify the timing of when to give epinephrine in the recent guideline. Epinephrine has an important role in improving coronary and cerebral perfusion during CPR. Early, within 5 minutes, administration of adrenaline from start of chest compression in pediatric cardiac arrest was associated with improved outcome in multiple recent multi-center data. Use of invasive blood pressure monitoring during CPR, patient with invasive arterial BP monitoring lines in place, it is reasonable to use diastolic BP as a guide for quality of CPR. Diastolic blood pressure more than 25 mm of Hg in infant and more than 30 mm of Hg in children during CPR was associated with greater chances of survival to hospital discharge and better neurological outcome. Opioid-related cardiac arrest, updated guideline emphasize the importance of routine CPR protocol over naloxone used in opioid-related cardiac arrest. This is comparison of intracardiac arrest to recent guideline with previous guideline. Airway during CPR in a pre-hospital setting, it is reasonable to ventilate and oxygenate infant and children with a bag and mask device, especially if transport time is short. In a recent guideline, bag and mask ventilation is reasonable compared with the advanced airway intervention in the management of children during cardiac arrest in out of hospital cardiac arrest. Respiratory rate, this is the main changes in this guideline. Previously, it is one breath every, for intubated baby, one breath every 6 to 8 seconds, that is 8 to 10 times breath per minute without interrupting chest compression. In recent guideline, it is one breath every 2 to 3 seconds, that is 20 to 30 breaths per minute, accounting for age and clinical condition. Previously, for poor efforts, inadequate or poor respiratory efforts or absent respiratory efforts, given one breath every 3 to 5 seconds, that is 12 to 20 breaths per minute. While in the recent guideline, that is for absent or inadequate respiratory efforts, it is reasonable to give one breath every 2 to 3 seconds, that is 20 to 30 breaths per minute. Then use of cuffed endotracheal tube. Previously, we can use either cuffed or uncuffed endotracheal tube. But in recent guideline, it is reasonable to choose cuffed or uncuffed for intubating infant and children. While we intubating with patient with cuffed endotracheal tubes, we have to focus on attention should be given to ET size, position, and cuff inflation pressure. That it should be less than 20 to 25 centimeter of H2O. Use of cricket pressure, that is previously for every unresponsive victim to reduce air entry into stomach. For in a recent guideline, it is cricket pressure during bag and mask ventilation be considered to reduce gastric insufficiency. Routine use of cricket pressure is not recommended during endotracheal intubation of children. Early epinephrine, that was also in previous guideline, but in recent guideline, it is timing is within 5 minutes of starting chest compression. Use of invasive EP monitoring during cardiopulmonary resuscitation, it is in previous guideline also to assess the to guide the CPR quality. While this is in the recent guideline, it is mostly reassess the invasive pressure, that is specifically diastolic blood pressure, to assess the CPR quality. Opioid-related cardiac arrest, naloxone reverse the respiratory depression of narcotic overdose. While in recent guideline, more focus or more recommended that more focus on high quality CPR compared to naloxone administration for opioid-related depression, respiratory depression. Post-arrest care, that is targeted temperature management. Continuous core temperature management is recommended for post-cardiac arrest patient, both in hospital or out hospital cardiac arrest. Hyperthermia should be strictly prevented. Either hypothermia followed by normothermia, or only normothermia had a similar outcome at 1 year in 2 pediatric RCT. That is almost same in recent or previous guideline. Only emphasize in this guideline to prevent hypothermia should be strictly prevented. Hemodynamic monitoring and ventilation. BP is labile in the period following return of spontaneous circulation, and intermittent NIVP may be unreliable. Use of invasive arterial BP for post-cardiac arrest monitoring when available, and to maintain systolic blood pressure more than 5th percentile for age. Normoxemia and normcarbia should be maintained. Target SpO2 is 94 to 99. Neuro monitoring and seizure treatment, that was not in previous guideline. Continuous EEG monitoring is recommended following recovery of spontaneous circulation, as evidence has shown that the non-convulsive common in these children. Children with clinical or non-convulsive seizure following rate of spontaneous circulation have the worst outcome. No recommendation has been made regarding prophylactic use of anticonvulsive drugs in children without clinical or non-convulsive seizure. Prognostic following cardiac arrest, multiple factors including, but EEG, neuroimaging, biomarker should be taken into account for prognostic. That's almost similar to previous guideline. Recovery, a new addition to chain of survival. In hospital cardiac arrest and out hospital cardiac arrest have a very different outcome, and different chain of survival has been formed for them. Both these chains now have a new 6th component, which is recovery. Cognitive, neurophysiological, and physical impairment continue post-discharge. Ongoing assessment and support following hospital discharge is essential for improving long-term outcome in these children. This is comparison of recent guideline with previous in post-arrest care. Target temperature monitoring, that is almost similar to previous guideline. That is either normothermia for 5 days or normothermia for initial 2 days followed by hypothermia for 3 days for continuous hypothermia. In hemodynamic monitoring and ventilation, that is more that is almost same for both the guidelines, but specifically focus on SpO2 is recommended. SpO2 is 94 to 99%. Neuromonitoring and seizure treatment, that is not recommended in previous guideline. It is recommended in recent guideline. When the resources are available, continuous EEG monitoring is recommended for detection of non-convulsive seizures following cardiac arrest in patient with persistent encephalopathy. It is recommended to treat clinical seizure following cardiac arrest. It is reasonable to treat the non-convulsive status epilepticus following cardiac arrest in the consultation with expert. Prognostic following cardiac arrest, that is prognostic factor to assess the post-cardiac condition, post-cardiac arrest condition, that is EEG, neurosonogram, biomarkers. Recovery, this is main focus of recent guideline. In recovery, it is recommended that pediatric cardiac arrest survivor be evaluated for the rehabilitation needs. It is reasonable to refer pediatric cardiac arrest survivor for ongoing neurological evaluation for at least the first year after the cardiac arrest. Thank you.
Thank you. Any questions from audience?
जरा जास्त फास्ट घेतल्यामुळे ऑडियन्स जरा बरेचसे चेंजेस आहेत ऍक्च्युली.
I think there are no questions present. It is a big topic, and I think KAP will be planning this course very soon. So thank you, Dr. Subhash sir. Kumbaskar madam, any comments? Okay. Okay. Thank you, Dr. Amruta madam, Dr. Subhash sir, for your wonderful presentation. And I think we'll conclude the session. Kumbaskar madam, any comments?
नाही अमर, तुलाच काही त्याच्यात सांगायचंय का त्याच्यात यू आर बिंग वर्किंग इन इंटेन्सिव्ह केअर युनिट, जे अगदी मस्ट आहे आपल्या लक्षात ठेवण्याकरता चेंजेस इन CPR, एक कफ ट्यूब यू शुड यूज ओव्हर नॉन कफ. जे स्ट्रेस करण्यासारखे काही पॉइंट्स असेल तर तूच जरा रिव्ह्यू कर. थोडंसं फास्ट झाल्यामुळे लक्षात नाही राहिले ते काही गोष्टी. अदरवाइज ओके. ऑडियन्स मधून तरी काही क्वेश्चन्स नाहीये.
I think we have to go
Conclude
detail on that this topic, ma'am.
ऑडिओ क्वालिटी जरा हे रे, नीट
Thank you.
ऐकायला येत नाही.
So thank you everyone for listening patiently. And I think we'll conclude this session.
Thank you.